All right, colleagues. I think we are opening the webinar now. Just also to let you know that we are live streaming this on YouTube, so we'll be able to share the link for the YouTube as well afterwards, and then we'll also be streaming this, I think, on Facebook. Just connect, yeah, just make and we'll be recording this as well. So just wanted to let you guys know we've opened it up now for people to join in, and then I think we should be ready to start in the next 5 minutes. So let's give it about 5 minutes for people to join in, and we can start the conversation. Thank you all so much. Oh yeah, just quick one. I'm Wilson. I forgot to introduce myself. Wilson Chivanga. I'm the EDO for Equality, and I have my colleagues here as well. Jessica, who you've been in touch with. She's our communications and campaigns lead. And then we have Shalom as well, who is our programs director. So she will also come into the conversation at some point. So yeah, thank you so much, and talk to you again in a few minutes. So grab a glass of water, some coffee. I'm getting coffee because I need it, and then we'll start the conversation soon. Thanks.
Hello, everybody. Good morning. I see we have quite a couple of people now on the call, and I think in the interest of time, we will just go ahead and start. So good morning once again to you all. My name is Rugai Shalom Zimunya, and I am the Programs Director working with For Equality. We're very excited that you could all be here. Thank you to our panelists for being able to make it. And thank you as well to those that are joining in virtually from different parts of the world for being able to make it as well. I think that it's a very critical and important conversation that we need to have today around vaccine inequalities. We already know that we've had several inequalities and iniquities that have existed in our society for so long. And so it's sad to see that even with the coming of COVID, that also worsened a lot of these inequalities and also created some new ones. So issues around vaccine rollout, perceptions around the vaccine and solutions. Hello? Yes, sorry, I got interrupted for a little bit. Yes, and so I think that it's very important that we have this conversation. And more importantly, I'm a firm believer in, learning from one another and sharing best practices. And so and sharing best practices. And so I really think that this would be a great space to connect and learn what's happening across different sectors, whether it's the government, whether it's the civic space, whether it's the NGOs, or just people in the individual capacities, just to really learn what has been working, where do we see the gaps, and more importantly, how do we move on from there? Where do we see the opportunities in order to advance vaccine equalities and to ensure that everybody is a part of the movement and that nobody has to be left behind. So, and I also think what's critical at the end of today's conversation will really be to look into recommendations or action plans, a way forward to say, whether it's for policymakers or political leaders, for those working in the NGO space, for those of us who are working and are in positions of influence, how can we move on from here to ensure that we reduce vaccine inequalities, what needs to be done by the different sectors, and how do we begin to move to make this happen? So with that said, and with those few remarks, I just want to welcome you all once again to today's conversation. Really looking forward to learning more and hearing from the different experts that we have on the call, and also really interested to hear and see what comments come from those of us who are joining in virtually from different parts of the world. So with that said, thank you so much and enjoy the call.
Thank you so much, Shalom, for introducing the call. Welcome everyone. I guess we'll jump straight into the panel discussion. My name is Wilson Chivanga, and I'm the Executive Director For Equality, and we're excited to be co-hosting this webinar with our friends at Zamara Foundation. So thank you guys so much. Today we're joined by an amazing lineup of speakers. I'm really so excited to jump into this conversation with them. We are joined by John Paul Omolo from Kenya, George Jobe from Malawi, and Rachel Kawala. Well, through with us today. So before we jump into the conversation, I'm going to ask them to introduce themselves briefly, and I will start with JP. JP, please just introduce yourself to our audience today. Thank you.
Thank you so much, Wilson. Really appreciate it. It's my pleasure joining this great panel and this great discussion. And it's an honor also for Path to join and contribute towards addressing issues of vaccine inequities, because Paths are one of the key attributes of PATH is, ensuring that those who need commodities and medical products receive them whenever and when they need it. So my name is John Polomolo. I'm a public health specialist. I'm a health policy analyst. At PATH, I lead the health R&D and regulatory harmonization advocacy work that spans across Kenya and the continent. And I'm happy to be part of this. I think that would be great for now. Thank you.
Thank you, JP. George?
Thank you very much. My name is George Jobe. I work with the Malawi Health Equity Network, MEHEN. This is a network of over 90 civil society organizations in Malawi that are working together and are interested in issues of equity, responsiveness in the health sector, issues of access. We do a lot of activities that include advocacy in the health sector, social accountability, and community mobilization, as well as demand creation. So we sit on a number of fora, a number of committees, including when policies are being developed in the country. As Malawi Health Equity Network, we take this as a privilege that we are part and parcel of this panel. Thank you very much.
Thank you so much, George. And lastly, Rachel.
Hello. Hello. So my name is Rachel Chihana. I am a medical doctor, but also a vaccinologist. I work at Johns Hopkins Research Project in Malawi. At this research institution, we do a number of research through clinical trials and observational studies. And the research is on a number of health areas, which include HIV, but also vaccine and many other health-related research. And I'm also happy to be part of this research, panel discussion. Thank you.
Thank you so much, Rachel, and to all our panelists. I want us to jump straight into the conversation because we have quite a deep conversation that we want to have here. But before I invite my panelists to start, answering some of the few questions that are
George, we lost you. Wilson, we lost you.
Oh, sorry. Am I audible now?
Yeah, you're back. We lost you at
Thank
the
you.
point where you're mentioning that before you engage the panelist.
Yes.
Oh, sorry about that. My internet, I think, is a bit. Great, thank you. My internet was a bit shaky there. So I was saying before we jump into the conversation, there is a poll that we are running. So if you go on the post, you should be able to see a poll there. We are asking who is to blame for Africa's lagging behind in the whole vaccination program. So there are a few options that I just want to hear your thoughts around that. Who do you think is to blame that Africa is lagging behind? Do we think it's the greedy West? Do we think it's big pharma, pharmaceuticals that are causing that? Or do we think maybe it's poor leadership from the African continent? Or so we want to hear your thoughts. So please feel free to answer that poll. I'm sure there will be other poll questions that might pop up as we go along as well. But now let's dive straight into this. And I think I want to start off the conversation by just inviting, I'll start with JP, and then I'll also go to George. I want you guys to sort of give us an overview of the vaccination situation. In JP, you do work across the continent as well. So I'd really love to know as well from maybe a regional perspective, where are we right now with the vaccination program. So JP, please feel free to come in. And then after that, George, you can also come in to answer perhaps more specifically from a Malawian context, because you did touch on issues around equity, and are we seeing that equity, in the vaccination rollout here in Malawi? So JP, please feel free.
Thank you so much. I think there's a bit of shakiness from your end with the internet, but I hope it get better. But if I had you right, you indicated that I should speak about the vaccine situation, generally the Kenyan context, but also give it the continental touch. So I think to start us off, because when I looked at the context of our conversation today, it was talking about both vaccine equality or inequality and vaccine equity. Many a times we might be using these terms interchangeably, but at the practical point of view, these terms completely means different things within the health context. So if you'd allow me, Wilson, is just for us to frame it in the context of both terminologies, equity and equality, so that even as we be speaking about other things, we will be seeing, the context of the different, how equity and equalities are coming into play. So if I might just speak about the difference, so equality would mean, that we are providing individuals or groups the same level of access to the resources that are available. So here the resources is the vaccine. So if we have 10 different kinds of vaccines in the or in the globe, then everybody should be able to have access to that number of vaccine or of antigens. So equality would mean, just making sure that giving every person or everyone the same access to the same kind of resources. However, when we're talking about equity, equity recognizes the differences among people or among groups that would otherwise put these individuals at a disadvantaged position when equal measures are applied. So when you apply an equal measure to a group of people without considering the social, political, or any other difference that applies within that group, then you might be subjecting these individuals to an inequitable circumstances. So inequity recognizes that each person has a different circumstance that warrants that they, when allocating resources or putting in interventions, such as vaccines within that group of people, you don't assume that this is a homogeneous group, but that might require some special attention if one has to reach the desired outcome. So if you were to reach that desired outcome, you need to consider some of those differences at population or even at individual level, so as to reach the same kind of an outcome. I hope I didn't confuse as much with that kind of explanation. But to give us certain statistics, and these statistics I think will give us more in-depth understanding on how we are facing the inequalities, but also the inequities. Globally, we've so far, provided about 7.13 billion doses, and about 3.07 billion individuals have been fully vaccinated. This gives us about a 39% fully vaccinated population globally. But when we dig deep into African context, we see that the African population that has been vaccinated is just about 5.8, or let me say 5.9%. And remember, we have a target of about 20% of the population by the end of 2021. We are only a few weeks shy away from ending 2021, and we are still doing 8.8%. And we'll try and dig deep into this and understand, is the issue the supply, or is the issue the utilization, and we'll dig deep into this in the next, kind of presentation I think that I do have. But when you come to Kenya, Kenya has so far vaccinated about 5.3, or rather we currently have about 5.3 million doses of vaccines that we need to have provided, and we have fully vaccinated only 3.1% of the total population. So if you consider the total vaccines that we have received, we've received about 10.6 million and we've administered 5.3 million doses. So there's a big difference there. So already we have more vaccines, but the utilization is low. We've only consumed about half of that vaccine that we have. So if we have about 10.4, or rather 10.5, because it's 10,460,000, and we've only consumed 5.3. There's an issue around the utilization of that vaccines, and that cuts across, because if you look at Cameroon has so far received about 481,000 vaccines. They've only administered they've only administered 481,000, yet their supply chain is they've received about 2.2 million doses. The same happens with Tanzania, where they've received 2.6 million doses. They've only administered 744,000. Tanzania is a unique case because they came late into the game, and we all know why. But Zimbabwe is also a classical example where they've received about 12,000 or 12.7 million doses of vaccines, and they've only administered 5.9 million doses. So there's also a discrepancy between and within, if we are looking at the continent. And the question to ask, especially from an equality point of view, is what is currently affecting the full utilization of the available vaccines at country level? Because despite the fact that countries have vaccines, there's an issue about utilization of those vaccines at those countries. And we are seeing that most of the countries are doing slightly half of what they are, utilizing slightly half of what they have. Are there issues that we need to consider? Are there health system factors that we need to consider? Are there issues around vaccine hesitancy? Are we looking at political issues? Are we looking at other social determinants of health that are really affecting the utilization of vaccines? So those would be considered equality issues. But when now we get into some of the social determinants, and then look at the deployment plan of those vaccines, then we would start seeing equity issues coming into play. I would like to mention some other things around Kenya quickly. That currently, as I mentioned, Kenya has administered about 3.72 million doses, and we are seeing that we've vaccinated more males than female. If we look at the number that has been fully vaccinated, 53% of males, or rather 54% of males are the ones that have been fully vaccinated, and 46% of female have been fully vaccinated. Take note, there's a difference between the first dose, because most of these vaccines are double dose. So there are those that, however much we've done 3.7 million vaccinations, both that is first dose, the number that has been fully vaccinated is still lower, which is about 1.6. As I said, we are just doing half of that number that we've got. Only 1.6 have been fully vaccinated, and 54% are male and 46 are female. And that is a new twist again. When we're talking about equality issues, more often the best people, or rather the people who utilize healthcare services more, especially in sub-Saharan Africa, has been more female than male. But we've seen that COVID-19 has been gender biased in terms of it affects more male than female because of a number of factors. And we are seeing that culminating in even the utilization of vaccines at the country level, because we are seeing more males getting vaccinated than female. So even as we are going to put in structures for the deployment of vaccines, we need to start looking at how then do we reach more female, or we get more female to get vaccinated equal as the male. Also to mention that Kenya has gone further and segregated data into intersex and transgender. And so far we've fully vaccinated 1,630 intersex and transgender individuals. Or rather, intersex are 1,630 and the transgender are 769. So if you look at that, we are not doing badly off, but compared to the countries that are around us, but we need to do better, because we still have a huge target if we are to get to at least 20% of the population. And of course, currently we are having about 5 antigens in the country. We have AstraZeneca, we have Sinopharm, we have J&J, and we are also having Pfizer and Moderna. And there's also some equity issues that needs to be looked at, even as we are thinking about Pfizer and Moderna. The deployment plan for certain vaccines are not really framed for the context under which we are working in, unless we revamp and strengthen the health system. When we are asking, who are we to blame? If the manufacturers have produced vaccines that require ultra cold chain equipment, and certain countries do not have ultra cold chain equipment, are we to blame the manufacturer or are we to blame the country? Because the vaccine could be available, but the vaccine cannot be deployed in that country because of the cold chain capacities that are there. And of course, to get to this point, to get to the point where now Kenya is with all this, Kenya really put in a number of mechanisms. One of them is that we had, a national task force, COVID-19 deployment task force, that then below them had a number of subcommittees. We also conducted a number of training of healthcare workers to be able to understand, first of all, starting with the AstraZeneca, and right now we've conducted multi-vaccine deployment plan trainings, where we are training about the different vaccines and the antigens, how to handle them, how to inoculate, and how to handle the waste out of them. We've done a lot of social mobilization, including public sensitization activities, and also carried out a number of cold chain optimization exercises. But that is just for Kenya, and I've seen that also across a number of African countries. But that is not enough to be able to fully reach our target by 2021. Back to you, Wilson.
JP, thank you so much. I mean, you raised quite a number of pertinent issues here that I will come back to you on, that we need to talk about a bit further on. But I want George to piggyback on what you have just shared, because I know they are doing a lot of work around health equity, and I want him to come into the conversation from that perspective, from Malawi as well, to share what is the current situation, what is happening, and I'm sure he might share some details around Southern Africa as a region as well. So George, let me quickly come to you to jump into the conversation.
Thank you very much. I think you can hear me. About Malawi, around December 2020, we started discussions about COVAX facility. I should say that here in Malawi, vaccines are managed by the expanded program on immunization. In short, it is EPI. And I remember in December, there was an emergency meeting that we could come together. We are a member of that as a civil society organization to discuss about the COVID-19 vaccine, that as a country we could consider applying to be included. So we made a decision to apply to be included on COVAX facility. And the application was done, all the necessary documentation was done. Then we received our first consignment, which was the 360,000 vaccines, AstraZeneca, in March, early March. Precisely, it was on 5 March. And then just a week after, a few days after the vaccination started, like enough, here in Malawi, the first people to go to the vaccine were the president and the vice president. Let me mention here that by the time we received the vaccine, a lot of negative information had made ways in our public social media about the vaccine, other people saying someone can die because of it, talking about religious beliefs, that it is equated to the end of the world, it is 666. So it was a tough period at that time to sensitize people, to make sure that people can receive the vaccine. Then a few weeks after, we got a donation from the government of India. That was about 50,000 vaccines. And then the AU also donated about 102,000 vaccines to the country. And the vaccination took place. What was required was that the vaccine must move to the people and the healthcare workers must be trained. So these issues had to happen. And an element of equity came in. And we are very much interested in equity ourselves, as even in our name, Malawi Health Equity Network, we are there. And when we look at equity, apart from my colleague, how he, in addition to what he defined it, in ourselves, we are interested also in the vulnerable, the most vulnerable people. How can they be supported? Those who cannot go to a private health facility, and those who are in rural areas, who are in hard to reach areas, how can they access? Those who don't have means of transportation. So when we started, we noted that the most advantaged were those in the towns and cities. And especially that in the districts, some of the healthcare workers, especially in rural areas, had not been trained to vaccinate. So they had outreach clinics where they would move, or mobile clinics, they would move to a particular area, announce that we are going to come on this particular day, and they would go to another area. So even some of the times when people were ready to get vaccinated in the rural areas, they could have to wait, or they would have to go to the headquarters of the district, which in Malawi is called a Boma, to get the vaccine. So that helped, affected quite a lot negatively, and we engaged Minister of Health and other stakeholders to talk about it, how the rural areas should be supported. And again, when we are talking about equity in the vaccine, other issues also come in. We are looking at logistics, transportation to go to take the vaccines to the people. We are looking at the availability of other supplies like syringes and the like, and the cold chain. Apart from the central level where we keep the storage, the cold storage for the vaccines, but when community health care workers are moving to the vaccination points, they have cooler boxes to carry the vaccines with. Those we are happy that when the vaccines came, they also came. And yet I have also talked about personnel. Let me also mention that in Malawi, we have the Presidential Task Force on COVID-19, as we have heard about Kenya, and we have several committees that meet every week. We have what we call a health cluster. It meets every week to discuss issues around outbreaks, including this time is COVID-19. We have an emergency operation center that also every day has been meeting to discuss issues. And as a key stakeholder in the health sector, we are happy that as a civil society organization, we have been part and parcel of all these committees. We are there, we sit there, we make contributions, and we are even asked as Malawi Health Equity Network to make presentations on behalf of civil society organizations in Malawi. When the vaccines came, I talked about the 360,000 that came from COVAX. I talked about the 50,000, but let me also mention, you might have heard that in Malawi, we destroyed some vaccines that expired. It was part of the 102,000 that came from the AU. Understandably, it came when the vaccines would expire in 2 weeks. And it came the time we had not yet prepared the people. Other people were still, had still had negative feelings, although we still have some of them now, but at that time it was very intense. So to have vaccines that would expire in 2 weeks, much as the healthcare workers tried, we saw some of them going to bus depots, going to markets, shouting, can you come and get vaccinated? But still we had to destroy about 19,000 vaccines, which was bad, and it dented our image. In that case, we also came in as Malawi Health Equity Network to talk, especially to our development partners, that when they are making donations, they should also consider the lifespan of the vaccine, rather than to get something which would expire in a few days. We're happy recently, around August, if not July, when we were expecting a consignment to come, and then we heard from the Minister of Health that that had been postponed. Can you hear me?
Yes, George, we can hear you well. We can hear you quite well.
Okay, thank you very much. The consignment was postponed, that we could not receive it because it was about to expire. So we are happy that the consignment was stopped before it came to Malawi. At the moment, we have 2 types of the vaccines. We have AstraZeneca, and we also have Johnson & Johnson. We are expecting to receive Pfizer towards the end of the month. Now, when we are looking at how the vaccination has been affected, we have talked about the myths. Our understanding as Malawi Health Equity Network is that COVID-19 has different faces. It has political issues. We have seen politics in COVID-19 because COVID-19 came when in Malawi we had the cases in the political cases in the courts. Then we go into elections. So it has been an issue. It's a social issue. It has been difficult to manage funerals, for example, markets. Those have had an impact on COVID-19. When people are gathering and there are some limitations, you cannot go and control them. Sometimes some of them think that there's no COVID-19. It is an economic issue and a social issue, as I have already said. Now, issues of equity. We can look at equity at the national level, and we can also look at equity at international level. At national level, towards the end, like from last week, last month, we have seen a lot of efforts now to take the vaccine closer to the people, moving closer to the people, which to us shows that as many healthcare workers have been trained, because in equity, those who cannot find transportation means need to be reached wherever they are. In equity, there are some discrepancies in how people can acquire information. Those in cities have exposure to radio, newspapers, and televisions, which is not the case in the rural areas. And our wish, and this is what we've been talking about as a civil society network, that when these donations come, at least there should be a package as well for awareness raising, because we need to be informing people as much as possible. And when we are talking about the mobile clinics, as they are moving door to door, there is also need for more resources for transportation to avoid having any antigens expire, what we have been advising is that our community healthcare workers must go out to a community, let people that we are coming in 2 days' time and register how many people are ready to get vaccinated, so that on that particular day when they are going, they should just take enough for those who are ready to avoid having the vaccines exposed more times. And now we are also looking at the international level. Malawi at the moment has a population of about 18 million. And the intention of Malawi is that 60% of the population should be vaccinated, which is close to 11 million. COVAX committed to support about 20%, in which case we need other partners to come and support the 40%, which we have seen happening. My colleague talked about the percentages, figures that we have not vaccinated more as compared to the West. In Malawi, at the moment, we have vaccinated about 1 million people, which is close to 5.6, 5.5 or 5.6%. So here we're talking about both AstraZeneca and Johnson & Johnson. For AstraZeneca, we know people are supposed to get 2 dosages. So in total, those who have been fully vaccinated is about around 600, which is 3%. We need to vaccinate about 11%, 60%, which is 11 million. So we can see that this is not easy. For this to happen, we need the vaccines to be available. Because someone can come and say, you have not vaccinated more. But at the moment, do we have enough vaccines for the 11 million? If all the 11 million people wanted to get vaccinated, do we have such vaccines? The answer is no. We need more decisions to come. And as I said, we need that to be accompanied with the resources for awareness raising so that people know. One other challenge we have noted is
George,
yes.
Can I ask you to pause right there? I will come back to you because I think the other issues you are touching on now, I want us to address them, especially around what are the urgent needs and what are the key asks that we are giving. So I will come back to you on that. Let me quickly bring in Dr. Rachel into the conversation as well. Rachel, I want you to also piggybacking on the foundation that has been laid here, but I know you come from a research background as well, and I know we've talked a lot about issues of utilization being low, and so from that perspective, what is the reason, what is going on, and how are you assessing the situation from your perspective as a researcher, but also as a vaccinologist? Why is utilization low? So if you could come in from that angle, and then we tie this foundation quite well. Rachel, so please come in there.
Hello, thank you. Because of my internet is not so great, so I'll not use the video. I'll only use the audio. So I think my 2 colleagues who have spoken before me have alluded to the matter very well. But I just wanted to emphasize that the issue of vaccine equality is not it's not a political concept or just a mere concept, but it has to be considered as a public health concept, because when we bring in the vaccine equality issue, especially with the COVID vaccine, it means we're bringing in, it's in everybody's interest, because COVID-19 is a global threat. And for as long as we have vaccines, as long as we have populations that are unvaccinated anywhere in the world, that would mean that the threat of this global pandemic will still exist. So we have seen that on a global picture, we have seen that the richer countries have had more people vaccinated, about 60% so far, that have received at least a dose of the vaccine, while only 5% from the poor countries have received at least a dose of the vaccine. And therefore, this would bring in so many problems. One of which I want to mention from a researcher point of view, or from a vaccinologist point of view, is that if we have pockets of unvaccinated people, this means that we give room to the vaccine to develop, to mutate, and therefore develop into more deadly variants. And this would mean that as long as we think that as a world we're progressing in combating the pandemic, we'll be brought back steps behind if we continue to have people that are unvaccinated. So causes of the inequality are multiple, but from a researcher point of view, because that's where the moderator has directed my focus, one of the reasons why we have seen this vaccine inequality. Of course, we know that we have wealthier countries that are currently stockpiling vaccine doses. We've had what is called vaccine nationalism, where we've seen that there've been export barriers where countries that are producing the vaccines have been restricted from exporting them because they wanted to ensure that their own citizens were vaccinated. And we currently are hearing of countries in Europe or America where they are considering a booster vaccine for their citizens when we have people elsewhere who have not received a single vaccine. But also we know that there has been a manufacturing problem. And I think as a researcher, that's where I would want to focus, and that's where I would want to dwell in at the moment. There are several solutions that will come in to solve some of these causes of the vaccine inequality that I've mentioned. But we know that manufacturers have not, they do not stick to their contracts that they had with COVAX on how much vaccine they were going to provide to COVAX. And there was a bit of lack of transparency and all those things. And this eventually led to COVAX reducing its forecast of distribution of vaccines because of this uncertainty that had the manufacturing companies had brought about. And this is one thing that has to be cleared at the moment. It's one of the solutions that has to come in order to improve the situation. If pharmaceutical companies are more clear and are more transparent on their contracts, this would ease the situation. Because we know COVAX was a body that was set in order to make sure that the vaccines are distributed equally. Everybody has equal access, irrespective of whether they are wealthy or they are not. But also, as a researcher, I would look at providing licensure, sharing of licensure between pharmaceutical companies. So you look at transferring of skills or the know-how or the recipe, if I might call it, between pharmaceutical companies. And we know we have these vaccines, a lot of these vaccines being produced outside the continent. But if we have people sharing the skills, sharing the license, and sharing the know-how, then the technological transfer will also ease out because then we might have more manufacturers in Africa, and therefore ease out the situation in Africa. But I must acknowledge that this is something that has already started to happen as in the situation that is happening in South Africa, the technology transfer. So I think back to the moderator, my focus as a researcher would go into that. Thank you.
Thank you so much, Rachel. Now, I think we have done justice to really trying to understand the issues on the ground. And I want us to now take this conversation a step further. And I know, Rachel, you've already touched on the issue of COVAX. And I want us to quickly get into that because I was reading up and you know, there's quite a lot of talk around how COVAX is failed Africa, and the AU Special Envoy on this, Strive Masiwa, who was heading the African COVID-19 vaccine acquisition task team. I mean, he has been on record to to say that they were misled. They went to buy vaccines. As COVAX, they were not saying we want free vaccines at that point, and they were told by big pharmaceuticals that all the available vaccines are gone and so forth. And when they thought that the world was really coming together to see how we can collectively distribute and make sure that there is equity in the process. And he goes on to say the design of the whole system was flawed in the first place, because apparently the design meant that the richer countries would get 70% of their people vaccinated, while the least developed countries we're going to get about 20%. So he said from the onset, the whole facility and how it was designed was flawed, and it was unequal from day one. Now, my question then to you, all of you as the panelists, is: do we think COVAX is the way to go for Africa? I know, Rachel, you already touched on issues of, technology sharing and so forth. Are those some of the solutions we need to be looking to as Africa? So in this case, I'm really asking for us to say, number one, is COVAX the solution? But if it is not the solution, then what do we need to be doing as Africa? Because I think the numbers are clear. We are lagging behind. So I'll invite you to come in there. And maybe, Rachel, let me start with you. Then I'll quickly go to and I'll go to George as well. What do we need to do?
Hi, thank you. COVAX is one of the critical. It's one of the critical solutions to the problem. The COVAX idea was a brilliant idea, and the fact that it has met a lot of mishaps while trying to implement the idea is unfortunate, and we have seen the effects more on the African continent. So I think if we put in efforts in order to make sure that COVAX does deliver the idea, putting in more efforts towards that would also be a brilliant step to do. But otherwise, apart from COVAX just being the problem, I see that there are other solutions that we can bring in. So currently, okay, so for example, for COVAX, currently we know that we have countries, in richer countries, that have stockpiled a lot of vaccines. In order to revamp or assist or work together with COVAX, if COVAX would reach an agreement, perhaps with a short-term agreement, perhaps with these countries, so that perhaps they release some of these doses, and then an agreement that in the near future, perhaps these would be retained in one way or the other. We really feel like COVAX, or the African Vaccine Acquisition Trust, which also has the same aim, if they work hand in hand with the richer countries that currently have stockpiled vaccines, this would ease the huge deficit that we're seeing in Africa. But also, we know that through WHO had through an independent panel that WHO had instituted, there was a recommendation that at least 1 billion doses must be donated from these richer countries, and this is something that has not been done yet. So I think this is also something that must come in, but also from a researcher point of view, still going back to research, I think it's also through the technology transfer and everything that I've said, there are a lot of other factors that perhaps if we start to manufacture the vaccines by ourselves, even doing research just like the Western world did as quickly, and if we were took part as much as we did, perhaps the world as a whole would not have been in this situation. So as a researcher, there are other areas that include the research capacity, personnel, infrastructure, and technology that perhaps not as an immediate solution, but things that we should, going forward, we should look into so that we should, as a continent, have the same capacity that our colleagues elsewhere have. Thank you.
Sorry, I had been disconnected for a second. My internet is acting up. I missed the last bit of what you were saying, Rachel, but I'm told the others could hear you well. JP, please do come in and follow up on the same question as well, and then I will bring in George after you.
Thank you, Wilson. I think I would like to start with a silver lining here around COVAX. And I think it is important that we give credit where it is due. COVAX, the principle of COVAX, or the COVAX principle, was a great idea. One of the greatest that we would ever see during a pandemic response. That from where I sit is worth maintaining, with a few alterations, of course, because we know the intrinsic issues. Those alterations should be able to address the structural inequalities and iniquities that are currently entrenched within the fabric of this mechanism. COVAX has enabled us really achieve tremendous gains with the deployment of the vaccines in the continent, with some level of unprecedented speed that if we did not have the COVAX, maybe, as we are speaking right now about 54 member countries in Africa that currently deploying vaccines, maybe we would be seeing less than half. But let us also call out on where issues are happening. As my colleague has mentioned, Rachel, that the issue of nationalism, vaccine nationalism, has really affected the functionality of COVAX. Take note, COVAX is between a rock and a hard place. The biggest funders of COVAX are the high-income countries. And then the high-income countries went behind COVAX and got into bilateral agreements with the manufacturers. And from that point, the manufacturers then put the countries ahead of COVAX, and currently, even up to today, COVAX is still behind the queue, meaning the principle that we were trying to create of vaccine inequity is something that was structurally and mechanically put outside by high-income countries, by their high-handedness, by their greed, I would call this greed, and by the fact that they did not consider vaccine equity something important. And we kept on mentioning that with such a pandemic, no one is safe until everybody is safe. So until we are able to address these intrinsic systemic issues that are currently happening before our eye, we need to call them out. I think it is critical for us to remember that some of these social systems are naturally inequitable and they spur iniquities. And they've been intentionally designed to reward specific demographics for so long as for as long as those systems come into play. And that may intentionally create the level of inequities that we are currently seeing with COVAX. So if we are to address the issues of COVAX, then we must start with the very individuals who, on one hand, are providing resources to COVAX, and on the other hand, are making sure that COVAX is not able to provide and do what it is meant to do, to address vaccine inequities across Africa. So if you ask me, is COVAX the way to go? At this particular point, because of the global village that we are working in, yes, it should be a mechanism that we would want to uphold. But we must also then anchor it into other mechanisms that support COVAX. We have the African Vaccine Acquisition Task Force, Task Team, AVAT. We have the African Vaccine Delivery, AVDA, the African Vaccine Delivery Team, and many others that then can now translate the work from the global perspective to continental perspectives. And then we must also create mechanisms that, let me call them the accountability mechanisms, that would then put people to put some level of checks and balances on certain mechanisms like COVAX that are globally led, but somehow there's no one that is able to really call out on the ills that are happening right within the mechanism, and also the individuals that are driving this. So how then do we put in mechanisms that are able to, accountability mechanisms that would be able to call out on issues and streamline some of the issues that are not happening right? I think that is what I would mention and call out for on this issue. Thank you.
Thank you, JP. I think you rightly allude to the fact that we need to give credit where it is due, that the facility was a brilliant idea, but there are gross inequalities, that are underpinning the whole system that need to be addressed. And I really think that's a conversation we need to have. I was listening to speeches by our leaders at COP26. And I know it's a climate justice conference, and I really expected to hear more around this. And unfortunately, very few leaders, African leaders in particular, really use that opportunity as well to bring these issues to the fore. I know the Prime Minister of Barbados gave a very arousing speech to that effect and really called out the inequality. And I think it's a conversation that we really need to have. So thank you for bringing that up so strongly. George, let me bring you into the conversation as well. What is your thought on this before we move to my last question, and then I open it up to our wonderful audience to also ask a few questions?
Thank you very much. I want to agree with the JB that COVAX was a good initiative. As I said earlier on, that we are a beneficiary of COVAX. We made a decision to apply, to be considered. Then on 5 March, we received our first consignment. Of course, at some point, as a country, we did not have vaccines. There was a delay. We understood it was because India was not exporting AstraZeneca. And to some extent, we're thinking or attributing that delay to COVAX facility. But it is a good initiative. If anything would want to just improve, that is what we would need. As we said, that Malawi is targeting to vaccinate about 60% of its population. And COVAX committed to give vaccines for 20%. At least if this were based on the need of each country, how much a country needs, and it must be given. So what is happening now is we are moving around, trying to also approach other development partners. We see World Bank coming in. We have seen the Indian government, the AU coming in. But I wish if COVAX just looked at the needs of each country and commit to support everything. Then when we are also looking at the inequalities that have happened between the developing and the developed countries in terms of coverage, I'm just thinking also that if COVAX could have just saved the whole global, including those rich countries that are pumping money, the development partners are pumping money into COVAX. If they could take their money, put everything, the resources into COVAX, and then COVAX supporting all the countries, so that if another country has the more resources, at least all that should have been seen to be pushing every country, everyone on earth to get vaccinated. My colleague has already said that we are only safe if everyone is safe. So having only developing countries to be getting the support from COVAX and the others supporting themselves, I think that is the one thing that could probably have been considered for improvement. But it is a good initiative. We just need to be assured that all the vaccines will be made available, and the COVAX should continue to be busy with the resources mobilization to adjust the percentages that were committed to the countries. Thank you very much.
Thank you so much, George. I think we've really touched on this issue of COVAX, and we are noting down all the suggestions and recommendations that are coming out around how do we make this facility better. But I want to conclude my line of questions with asking more specifically, looking at the issue broadly. You know, all the issues we've talked about COVAX, we've talked about issues of utilization, which is low. I know, JP, you touched on issues of vaccine hesitancy as well, and so forth. So looking at the issues broadly, what are the key asks that we are making? What are the key recommendations that we are giving out to governments, to policymakers? Because like I said, this is a long overdue conversation. I know there are a lot of conversations happening around this, but I would want us to utilize this space to add our voices to that regional conversation as well, and even national conversation, to say what are the recommendations that we're giving. I know for the case of Malawi, we're going to be sharing the recommendations that are coming out from this with the Ministry of Health as well, but would really love to really add our voices to both the national and the regional discourse on this. So I'm going to ask our panelists to just come in and say, what are the key asks, looking at all those issues that we have that we want to present, maybe as recommendations to policymakers and our leaders. So JP, I'll start with you, then I'll go to Rachel, and I'll close with George.
Thank you, Wilson. I think that's the million-dollar question here. What are some of the key recommendations? I think, and I will start from that principle of, the oneness. The best outcomes during a pandemic are usually achieved when countries, donors, individuals come together through some level of a concerted effort to address the issue, right? And it would be important that within the context of oneness and embracing the idea of oneness, and we always know that, the divide that we currently see in Africa is really detrimental to health and its economic growth. So we must, first of all, embrace the idea of, having the Africa Vaccine Acquisition Task Force, and we need to fund it. As you know, Africa CDC or Africa Union, let me say the African Union, managed to procure a number of doses, J&J doses, through the AVAT, and Kenya alone, through its internal resources, managed to get, or rather procure about 13 million doses of Johnson & Johnson. And several other African countries are within that. So embracing the idea or the principle of one Africa is a key thing towards not only this current pandemic, but even future pandemics, or even our current endemic issues like HIV, TB, and malaria, are we able to go and confront these issues as one Africa? If we are to win the war, we must start thinking as one Africa, what I would call the United States of Africa. That's one thing. The second thing that I would talk about is let's start shifting our minds from technology transfer to technology co-creation. We must start removing our thinking capability as Africans and African leaders from always wanting to receive to wanting to do it with the people. Because the more we continue receiving, technology transfer means somebody did it somewhere and now we bring it to Africa. We must run away from that from this point. We must start asking for technology co-creation. If we are to do things, I like there's usually a slogan, I think I'm still a youth, by youth group that says, nothing for us without us. So until we start doing things that are addressing the needs of Africans, using Africans, right now we have Rachel here, who is a vaccinologist. Such kind of, expertise as they're being built, we need them to be done within the African continent, addressing African problems and providing African solutions. That way, we will be able to build our systems and our structures that are sustainable beyond eternity. Systems and structures that really address the needs beyond the issue. I think we keep on saying, we documented issues around Ebola, but did we learn about Ebola? What is it that we learned? And have we used the lessons there in this current pandemic? The things that we need to start thinking. Did we use technology transfer that time, or did we co-create technology? Because when technology transfers happen, then at the end of the day, people document how things happened well. But the people who are left behind do not have then the knowledge or even the capability to be able to continue doing that without those who brought the technology sometimes. So technology co-creation is something that I would champion for, and something that I would continue asking our, political policymakers to embrace. And of course, the last thing that I would like to mention is that you can have everything. You can have all the tools. Like now, I pointed out the health system issues that are affecting the deployment of vaccines. We have vaccines, and classical example, and I'm sorry to use the Malawian example. If Malawi's health system was optimum enough, then whether you have vaccines that are expiring in 2 days' time, and your health system is capable of, the supply chain is capable of moving those vaccines from the central store to the last facility, the last mile, then you would have used those vaccines. But we cannot blame the expiry, 2 weeks of expiry. I mean, those are 2 good weeks. If your health system was capable or was operating optimally, and I'm not saying Malawi alone, Kenya is also another example, then we would have been able to deploy those vaccines from the central store all the way to the last mile. So we need also to ask our leaders, how can we use and learn from this pandemic to be able to strengthen the health systems, right from the healthcare workers, the cold chain, the leadership and governance structures. We saw some countries that you even had, COVID-19 fund, and then at the end of the day, the whole money disappeared somewhere. So issues of leadership and governance, issues of data, how are we building on the data systems so that we are able to know right from the bottom the number of people who need these vaccines? Like now, most countries in sub-Saharan Africa, the first set of individuals who are to be vaccinated are healthcare workers and people with comorbidities. Trust me, there are countries in sub-Saharan Africa who cannot really give you the actual number of healthcare workers operating and working within those within their healthcare system. So how do we also build, the health systems, all the 6 pillars, and the 7th pillar here is issues of the community involvement. How much are we involving communities right from the very beginning? The reason as to why, we could not deploy and some of the countries have had to destroy some of the vaccines is because the level of preparation of communities right before the vaccines came into play was not optimum. And communities were asking questions and there was no one responding to those questions. How do you then expect the communities to consume these vaccines when the questions they were asking were not responded to? And even some countries, they did not provide platforms where, communities would interact with the healthcare system, with the decision makers to respond to the needs and their issues around these vaccines. So how are we also communicating and proactively as opposed to reactively responding to vaccine issues? We need to build that. So with those, I would close. Thank you, Wilson.
Thank you, JP. Thank you. Rachel?
Thank you. So I will speak specifically for Malawi. So I think that recommendations towards policy must really go to policies that affect health. So, for example, utilization currently has been low, and just like my Malawian colleague George mentioned, most of it has been due to vaccine hesitancy, and the hesitancy has been mainly because of misconceptions towards safety and efficacy of the different vaccines that we have at the moment. And I really think that if we put in more recommendations, these must go towards how we should educate the communities. Definitely, Malawi has a long way to go in terms of educating the community on just the general misconceptions that are there towards the vaccine. But also, the health-related recommendations that are provided would, because I think the COVID-19 has emphasized the point that health access is a problem in Malawi. And indeed, you could see, just like I think JP had mentioned before, as long as we've spoken about global inequalities, there's also vaccine inequalities that can be created nationally because we have different groups of people, the rich and the poor as well, and so many other factors that bring in health access problems. So this COVID-19 really has brought in a clearer picture that health access is a problem in Malawi. And of course, currently the mobile COVID vaccine clinics and other efforts are coming in to solve this solution. But I think going forward, if it's for COVID pandemic or other pandemics, policies must really direct through health and health access. And I can't overemphasize on the point that JP has mentioned on revamping the health system. I think we've seen how COVID-19 has torn apart the health system. I think basically that's what I would mention briefly towards recommendations to policy. Thank you.
Thank you so much, Rachel, for that. Lastly, George.
Thank you very much. I want to with my colleagues, and also in addition, the COVID-19 vaccine is not just a vaccine. When we are talking about vaccination, it must be seen as a package, a full package. I talked about the logistics. The vaccine must move to the places. So whoever is supporting the developing countries must consider all these in that package. The supplies must be there. We know we have cards, vaccination cards that must be printed. If you don't have enough of them, then you cannot complete. Personnel, even if we required, as we are moving to rural areas on door-to-door basis, even if we required more healthy personnel and to avoid suffocating the health system, we can hire those who retired so that they can come and support. That is the part of the package. And I talked about awareness raising to dispel all these myths and the negative feelings about the vaccine, where even at the moment, we still have some religious groups and other people who can't believe it, who cannot believe or trust the vaccine. We have seen some other people who refused to get vaccinated, and some of them have died. So it must be seen as a package. The other thing is, when we're talking about the COVID-19, as I said, we should not just look at it as a health issue. We had 19,000 vaccines expire and destroyed, not based on the health system, but because the people socially were not ready. They were afraid. They needed awareness raising. So if we have the vaccine, we have a cooler box as a cold chain, we have the syringes and the healthcare worker, that is not enough. We also needed to change the mindset of the people in Africa. Our understanding, those who have little access to information, limited access, and have just been exposed to the negative information, they need the positive information. So I would say that we should not just approach it as a health issue, but it has different facets. A greater part of the vaccine is social, and that includes religion. Then lastly, we need the vaccines. For example, Malawi needs to vaccinate 11 million people. So we shouldn't, at least there should be continuous availability of the vaccines. We should not have any point where countries run out of the vaccines. So far, so good in Malawi that we have had a continued supply of the vaccines, which is very pleasant. That at the moment, one can just go to a facility and get vaccinated. But we need more of that so that we avoid a period of drought. That's what I can add at the moment. In conclusion, thank you very much.
Thank you so much, George. We have 9 minutes left until 12:30, Central African time for us to close this. I've requested all our audience, if you have any questions, please feel free to quickly type them in the Q&A, and I will give our panelists a chance to respond to them. As of now, I don't see any questions that are there. I'm quickly checking. I saw some comments that I would love to quickly just read out in the chat box, and then I will ask our panelists to maybe give their last thoughts, any other last thoughts, while we wait to see if we're going to get any questions. I think there is a lot of agreement in the chat box around around the issues of the disconnect of information, with rural areas being a huge issue, and a risk to issues around vaccine uptake and so forth. So I think there is agreement that this is a huge issue. I don't know if there are any other questions. If any, please feel free to quickly type them in the Q&A, and we will ask our panelists to close this off. Now, while we are giving those few minutes, I will come back again to you, JP, and I know we have spoken quite a lot around, issues of, the vaccine hesitancy and so forth. I was wondering if, with your work that you are doing in Kenya and regionally as well, what are some of the best practices, maybe that you have seen, that you have encountered, that are working around, or even from learning from other countries outside of the continent? Are there any, best practices that we could also talk about quickly and incorporate in our response as well? Because I think that's one of the key issues that we need to address, real practical solutions and best practices that we could implement. So I'll quickly come to you, JP, and then ask Rachel and George to also add if they have anything to add to that. Thank you.
Thank you so much, Wilson. I think the issue of vaccine hesitancy is a big issue, not only for COVID-19 vaccines, but even other routine immunization or routine antigens. And I think, and it is also not unique only for Africa. Up to today, we also still seeing a similar kind of issues, you know, in Europe and US, you know, some level of hesitancy. We have anti-vax and as such. But what are some of the best practices around, you know, introduction of antigens, including COVID-19? Number one is to develop a very clear crisis communication plan, or what I would call a communication plan that include crisis communication. And each country at the very beginning needs to have that communication plan. Some countries call it advocacy communication and social mobilization plan, ACSM plan. Some countries call it a communication plan. And most importantly, being that human beings are social beings. And when I say social, when you socialize an issue with people early before you introduce the thing, then you find that the level of resistance or even the issues that people would be having are usually addressed before the intervention. So we need to start embracing that early in advance. Number one, early communication. So being proactive than being reactive. Governments must start by doing that. Be reactive, be proactive in addressing the needs of the people. Secondly, we need to provide the portfolio of issues that would either go right or go wrong. With vaccines, we know that there are things we call adverse events following immunization. And some of the adverse events following immunization can be drawn from what we call adverse events of special interest. These adverse events of special interest are some of the things that could easily happen and can be drawn from the way the disease itself is presenting, especially if we are using parts of a virus like adenovirus. Like now, you know, AstraZeneca is an adenovirus. It's different from the mRNA platforms. So if we're using parts like, when I say adenovirus, it's a part, we are using the spike, and maybe Rachel would be best placed to talk about this. We are using the spike of the virus to elicit the immune response. So when we are using something that looks like the virus, then there are possibilities of having a reaction that looks like the disease. So when we are able to communicate that, yes, when you get these vaccines, these are some of the things you might face. You might have fever, you might feel sick, you might feel lethargic, you might even feel some level of nausea, you might, you know, so that people start seeing that. And when they experience that at the point of vaccination, people don't panic. Because the problem is when we don't communicate the adverse events following immunization and people start experiencing certain things, then that is the information that starts going out and everybody panics and no one wants to experience that and say, you know, people will say these vaccines is making people sick. Even those who are not having COVID start having COVID symptoms. But until we are able to express that early in advance, we would be able to allay the fears, you know, from the community. So communicating the portfolio of issues that would result out of a vaccine is a step towards the right direction. Thirdly, and this is now broader, it might not be the simple and easy ones. We need to start conducting clinical trials within the African continent that are sampling the African gene pool so that people start experiencing clinical trials, vaccine work, therapeutic work early in advance, and they would be able to trust the system that is undertaken. One of the reasons as to why we saw a lot of people pushing back on these COVID-19 vaccines was because the information people had is that vaccines take 10 to 15 years, 20 years to get into the market. So everybody was asking, how did we then get vaccines in less than 1 year? And we did not communicate that this SARS-CoV-2 We have other SARS-CoV. We have other types of viruses that look similar to this, with a difference in the DNA. And we already had, some of these vaccines that we were using for some of these viruses that we only needed to tweak a little to fit into the context. mRNA vaccines, we were already doing this with, cancer cases, and it was very easy to tweak this with the COVID-19, with the SARS-CoV-2, now the virus itself. So we needed to have communicated this over and over and make this a song that the normal citizen is able to sing, so that by the time the vaccines are coming into play, then they really understand why it has come and they don't push back simply because it's taken 1 year. So how do we then communicate even the R&D process to the local citizen who is working somewhere out of the health field? How do we socialize this among them, and how do we make them part of the R&D process from the very beginning, so that when we go through such kind of R&D advancements and technologies, people would be able to understand and take up these commodities and products? Over.
Thank you so much, JP, for that. I think that there is a lot of great recommendations that we can take up, best practices that we can all take up across the region. I just received one question which I'll read out, and then I'll ask Rachel and George to quickly touch on that, and then we close the conversation. Daniel says, in terms of capacity, especially on academics and expertise, to develop our own vaccines as Africa, how good are we on that? Is there any health professional grouping so far in Africa that has started engaging heads of state to team up and put resources together and start developing vaccines? If not, can't that be one of the steps to take now? So that's a question, and I'll ask Rachel and George to quickly comment on that. Are there any groupings in Africa that have started engaging to put resources together? And if not, can we do that now? And how good are we?
Thank you. Thank you for that question. I think I'll tackle part of it, and my fellow panelists will assist. So we know that the reason why we are here as Africa is because of our research capacity. So we lag so much behind in terms of research capacity, and that I think I had mentioned before. That includes scientists. We know that the numbers of researchers globally is skewed with very few researchers in our continent. And even just to talk about capacity as well in terms of infrastructure and lab equipment and so many other reasons as well. So I must say that in terms of capacity and manufacturing, I know that I think I had mentioned technological transfer before, because I know that some other African countries through that means have started to manufacture. And I think to manufacture the COVID vaccine. And the reason why I had mentioned technological transfer as kind of immediate solution at the moment was because we know that the COVID vaccine wheel has been invented. So why reinvent a wheel that has been invented? But of course, that does not limit us from then developing it further, reducing side effects or increasing immunogenicity and things like those. So indeed, as Africa, we need to do better, but the challenges at the moment are a lot for us to conduct perhaps like manufacturing or clinical trials, just like the rich countries are doing. But we have seen COVID vaccines trials coming to Africa. Also, where I work at Johns Hopkins, we are engaged in some COVID vaccines as well to see how these vaccines can work better in different situations of people and things like those. As of heads of state coming together to help out with research situation, I am not sure, maybe my other panelists might assist, but I know that we have the rich countries, the G7 countries that have the richest economies, who have been discussing on how they can ease up the situation in terms of the vaccine inequality and the distribution of vaccine. So I think partially I might have answered that, but my colleagues can assist. Thank you.
Thank you, Rachel. George, as you come in, I want you to, there's another question here, which I think you can tackle, and then maybe if there's anything you want to add to the previous question, and this will be the last question we take because we're 4 minutes out of time. So I'm just going to extend with another 5 minutes so that we take this last one. Griffin says, good presentation from the team, and JP did justice to the issue of hesitancy. Kenya is experiencing this in so many ways, and is asking if there are any good practices from Malawi that, you know, colleagues from across the region can also learn from. And is also asking what is the role of media in misinforming the public. So George, if you could tackle that, then I'll quickly ask JP and Rachel to give closing shots in, 30 seconds each, and then we close the conversation.
Okay, thank you very much. One of the ideas we have been putting across is making sure that we use already existing channels of information, of communication. In Malawi, we also have risky communication interventions. And we have been recommending, which we think is one of the best ways to address vaccine hesitancy. We have chiefs, for example, who look after villages. We have different committees, development committees at the area level, village level, even at the markets. Malawi has worked hard to train them, including religious leaders, on what COVID-19 vaccine is. And our recommendation has been, and we think this can be taken, that these should not only understand the COVID-19, but they should also be agents of communication. If someone gets a message from their religious leader, a sheikh or a pastor, it will have more impact than having someone comes in the name of an expert. So if we can use such means, it would be important. The other question that has been coming, for example, when we only had AstraZeneca, was the why AstraZeneca? Why not Pfizer? Not why JJ at that time? Of course, now we have two choices. So we can say that when we are giving out information, let us think of explaining, giving more information. My colleague talked about being proactive, and then justify why out of several choices we have taken that choice. Then lastly, on the question which my colleague Rachel was answering, I believe that when we go to the West, we will find Africans who are there involved in research. So COVID-19 has taught us to rely upon ourselves, has taught us to make more investments in the health sector. There was a time in Malawi, one could not travel outside the country. We had to rely upon our own health system. And such efforts must also extend to research and development so that we are able to develop our own vaccines. We make investments into manufacturing, and for the developed countries, when it comes to pandemics like COVID-19, issues of patents, at least there should be sharing of some information, because as it has been said, the globe is not safe until everyone is safe. Thank you.
Thank you, George. Rachel, quick parting shot in less than a minute, and then JP.
Thank you. So I think my last words would be that vaccines work on a concept of herd immunity, and for as long as we have people unvaccinated somewhere, then this will remain to be a global threat. And also, I must mention that it's been projected that socioeconomically, in 2030, about 8 out of 10 people who will be directly pushed into poverty by this COVID-19 are likely to come from the developing countries, which is unfortunate, because if this inequality goes on, then the rich countries and the poor countries will be affected differently. And also, just the concluding remarks, it's also and developing countries are experiencing due to COVID might last up to 2024, while in the Western world, they might reach their pre-COVID per capita GDP growth rates probably by the end of 2021. So my urge is to see that what we have deliberated here and recommended comes to pass, that there is a fair redistribution of the vaccines so that we reduce the vaccine inequality. Otherwise, then we will, without that, the developing countries will suffer the most. Thank you.
Thank you, Rachel. I think you raise an issue we need to have a webinar on, the issue of the economic impact of the pandemic on Africa. So probably that should be the next conversation we have. Thank you for that. And lastly, JP, please.
Thank you, Wilson. I think because of time, I was itching to speak about the issues of manufacturing, because that's also now a huge area. But because of time, I think I will talk about the topic of the day, vaccine inequities. And I will say this is a multifaceted issue, and everybody has a responsibility to address. And from the conversations we've had today, there are things that each one of us, the youth, the women and girls, men in the society, women in the society, girls in the society, key populations and other groupings, everyone has a role to play to address the vaccine inequities. And as they say, the world is never full of bad people, but good people who say nothing, or good people who have the power, but are doing nothing about the issue. So all of us are those good people. We have the power. The small ways we contribute, even through such kind of conversations, we would be able to make the change. Thank you.
Thank you so much. Colleagues, I'm really glad we had this conversation. I really want to thank all of our panelists, George Chobe from Malawi Health Equity Network, Rachel Chihana Kawalazira from Malawi, who is working with John Hopkins, and JP Omolo from Kenya, who is working with PATH. Thank you. Thank you so much for being a part of this conversation. It's unfortunate that we had limited time. I mean, there's a lot we can unpack with this, but I really believe that the issues we have covered and the recommendations that have come out are key, and we will do our best to compile these and share so that we are adding our voices to the national and the regional discourse around this. So thank you so much. And lastly, I really would like to thank all the wonderful people who joined in our audience. Thank you so much for being here. We hope this was a great conversation. I've seen quite a number of comments in the chat box around great feedback around the conversation. So thank you so much for being a part of this conversation. And to our colleagues at Zamara Foundation, thank you so much for co-hosting this with us. To close us off, I'll hand back over to Shalom, who started the conversation, just to close us off. Thank you so much.
Thank you so much, Wilson. Just to say thank you so much to everybody for the participation. I think it's been really great getting insights into some of the progress that's been made across the different countries, as well as some of the gaps really that still exist. I liked how Doc, you mentioned how issues around vaccine inequalities are really public health issues, and so when you start to look at them in that light, it really informs a lot about the interventions that we do in order to address these issues. So thank you all for the valuable insights. Thank you so much for being a part of this call and for sharing the progress that's been made, as well as recommending the way forward, because we cannot just talk about the problems, but it's more about how do we then, what opportunities exist, and how do we leverage on these opportunities in our different capacities and contexts. So with that said, thank you so much to everybody who joined. We appreciate you. We hope that this was insightful and a learning experience for you as well. Thank you.